This video will cover the major lymphoid disorders covered in the PANCE blueprint. If you'd like a free copy of this document, visit past PA boards and click on free resources. The first disorder is a benign disorder of B lymphocytes, infectious mononucleosis. It's also known as mono, IM, kissing disease, and glandular fever. The most common cause, is Epstein-Barr virus, EBV. There are other causes like CMV. The incubation period is about 4 to 6 weeks. It's transmitted through saliva, but can be transmitted through any bodily fluids like blood, semen, and transplants. Symptoms include the classic triad of fever, pharyngitis, and lymphadenopathy. The pharyngitis is typically exudative with palatal petechiae, and the lymphadenopathy is most commonly posterior cervical. There's also an incidence of a rash associated with the use of penicillin, which is why the penicillin allergy is classically overreported. You can also see hepatosplenomegaly, fatigue, and the Hoagland sign, which is swelling of the upper eyelids. Diagnosis can be done with a monospot test, which is a quick in-office finger prick test. It's going to be positive within 4 weeks. The CBC can also show an increased white blood cell count, a leukocytosis, a monocytosis, and a lymphocytosis. When the lymphocytes are atypical, we call those downy cells. Now, atypical lymphocytes are not specific to mono. They're actually more broadly associated with viral infections. But if they are associated with mono, they're called downy cells. The CMP can show increase in the transaminases, the liver function tests, and serology, like for any virus, we can see IgG, which is typically persistent for life, and in the acute phase, and for the next 3 months, IgM. Treatment is supportive. We want to take caution if they have hepatosplenomegaly and we give acetaminophen, giving steroids only if there's an airway risk or low platelets. Precaution them to not engage in any contact sports, worried about rupture of the spleen. If the spleen does rupture, that will be evidenced by falling hemoglobin hematocrit, pain, and is sometimes treated with splenectomy. Next, we have ALL, acute lymphoblastic leukemia. This most commonly occurs in children, but there is another peak after 65, which is more refractory. Signs and symptoms include ANT, A-N-T. Those are the symptoms associated with pancytopenia, A for anemia, N for neutropenia, and T for thrombocytopenia, and all of their associated signs and symptoms. We can also see systemic signs and symptoms, fever, chills, weight loss, night sweats, arthralgia secondary to bone marrow crowding, and CNS symptoms if there's invasion. Good prognostic indicators would be a younger patient, lower white blood cell count, and specifically the L1 morphology. Diagnosis can be done through CBC, where we can see variable white blood cell count, but pancytopenia, biopsy and smear showing blast cells. There's a special stain called a periodic acid shift stain, and the most common morphology seen is L1. Flow cytometry is the gold standard for any type of leukemia, but the PANCE sometimes does still ask about special stains. The most common phenotype of cell involved is the B cell. We also want to do a lumbar puncture if there's CNS invasion. Next is CLL, chronic lymphocytic leukemia. This is the most common leukemia in adults, sometimes referred to as the most common leukemia in the West. Signs and symptoms are that it's commonly asymptomatic. They can have systemic symptoms. They can have the AMP symptoms of cytopenias. And we also have this kind of standout symptom of an increased response to insect bites. Diagnosis, it's usually an incidental finding on CBC where we have a leukocytosis and a lymphocytosis that's very dramatic above 5,000. Biopsy and smear will show small, mature lymphocytes. We can also, when we do the slide preparation, we see smudge cells, which are cells that are so fragile they fracture upon slide preparation. Again, leukemia, gold standard would be flow cytometry. Based on the morphology and also the physical manifestations, we can stage it with the RISE staging. 1 is just lymphocytosis. 2 is lymphocytosis plus lymphadenopathy. 3 is everything above plus liver spleen involvement, hepatosplenomegaly. 4 is everything above plus anemia, and 5 is everything above plus thrombocytopenia. Treatment, it's not always treated. Sometimes not treating it is better than over-treating it because it's typically a very indolent disease. It is treated if there are symptoms or it's progressive and worsening. Next, hairy cell leukemia, which is a subtype of CLL. Signs, symptoms, hepatosplenomegaly, can have signs, symptoms of cytopenias, and systemic signs and symptoms. It's diagnosed by the CBC, seeing pancytopenia, which means red blood cells, white blood cells, platelets all going down. The biopsy and smear will show what's pictured here, the hairy cells with the cytoplasmic projections. A test that you can use, another stain, is called the trap stain, typically relegated to history, but may still be performed and could possibly be tested. But again, leukemia best test and the rising gold standard is flow cytometry. Treatment is with 2-chloride-deoxyadenosine. Next, we have our lymphomas. Important to know what your B symptoms are: fever, night sweats, and weight loss. Non-Hodgkin's lymphoma is a heterogeneous group of many different subtypes. It's spread through the blood, so it has a worse prognosis. Our signs and symptoms are dependent on the location of the mass, which node or which organ is affected. Histology, there are different histological types, but the best prognosis is one that's follicular, and treatment is with CHOP and Burkitt. Hodgkin's lymphoma has a better prognosis. It's spread node to node, more of an orderly spread. Diagnosis: when we do a lymph node biopsy, we'll see Reed-Sternberg cells, the owl's eyes, the bilobed nucleus, prominent nucleoli. CBC is variable white blood cell count, may have eosinophilia, and the other abnormalities and laboratory derangements will be dependent on the location of the lesion. You can remember the mnemonic BBB. It affects B cells. It's bimodal, 15 to 35 and above 50, and is related to Epstein-Barr virus. Signs and symptoms: typically painless lymphadenopathy, can become painful after alcohol ingestion, and most commonly affects the left anterior cervical chain. You also have this classic Pell-Epstein fever, which is a cyclic fever and may have systemic signs and symptoms. Histology, the best is lymphocyte predominant, and the prognosis worsens as we have less lymphocytes and more Reed-Sternberg cells. And the most common histology is nodular sclerosis. Next, we have Burkitt's lymphoma, which is a type of non-Hodgkin lymphoma. It's rare, it's aggressive. Different subtypes of Burkitt's lymphoma are endemic, non-endemic, and immunodeficiency associated. Endemic is endemic to Africa, typically affects young children, and affects the jaw and facial bone. Non-endemic is outside of Africa and typically has GI manifestations. Immunodeficiency associated typically involves the CNS. The biopsy is classically the starry sky appearance.